Welcome to intubation training at the Albany Medical Center. The Department of Anesthesiology at Albany Medical Center has the responsibility for teaching medical students how to intubate the trachea before beginning their third-year clinical rotations. This video sets the stage for that experience. Anesthesiologists intubate patients routinely to make surgery safe, but we are teaching airway management to all medical students for use in emergency situations whenever they occur. Intubation constitutes one of those basic skills we commonly expect a physician to possess regardless of their specialty. Emergencies arise when least expected. Someone has stopped breathing and you are close by. Can you take care of this situation? At a cardiac arrest, the first procedure is take your own pulse. That good advice comes from The House of God, a pithy novel about medical training by Dr. Stephen Bergman. Bergman is saying something important in this tongue-in-cheek advice. For most physicians, grabbing a laryngoscope and endotracheal tube takes them outside their comfort zone. I'm expecting that even after watching this magnificent video and participating in our mannequin intubation laboratory, an emergency intubation will still dramatically quicken your heart rate. At times like this, a person's life or death can be decided by your skills. But we have a plan we hope will minimize your panic and turn your adrenaline-induced energy into an effective performance. As you can read here on the screen, I am currently doing a residency in anesthesiology. 2 other residents are going to appear in this video to talk to you about ways to help you become more comfortable with emergency airway management. In our lab exercise, you will have the opportunity to practice airway management on a mannequin.
We hope that having us residents do the teaching in this video will make the exercise less intimidating. Everyone speaking in this video remembers very well what it felt like to pick up a laryngoscope for the first time. Some gray-haired anesthesiologists who no longer remember their first intubation will be available to help you in the lab, just in case you have some burning question that goes beyond our level of experience. But if you listen carefully to this video, I think we can make you successful.
Before we jump into intubation, perhaps we should take a moment to think about exactly when patients need intubation as an emergency procedure. In years past, in cardiac arrest, physicians believed doing chest compressions without ventilation was a waste of time because it did no good to circulate blood that contained no oxygen. Today, new science has changed that view. Studies now show that cardiac compressions without ventilation do provide benefit by removing the byproducts of anaerobic metabolism from the cells of the heart and the brain. So, emergency responders are now taught to do vigorous chest compression and resist interruptions of those compressions, even to improve ventilation. This shift in emphasis takes a lot of pressure off of all of us. We don't need to rush to intubate in order to save a life. If you master ventilation with a mask and make good use of oral or nasal airways and focus on compression and early defibrillation, you can save lives without intubation. So while in the lab today, take time to master proper technique with a bag mask and with oral and nasal airways. These devices save lives. Notice the fit of the mask to the bridge of the nose. The rest of the mask will take care of itself once you fit the bridge of the nose. Also, ask to practice with a laryngeal mask airway, a good backup device for the patient who proves difficult to intubate. These devices may lack the glamour of intubation, but they definitely save lives and open airways for oxygen delivery quickly and efficiently. A finger or tongue blade can sometimes facilitate getting the tongue out of the way of the device. The lubricated mask airway will slide along the roof of the mouth and turn down into the airway. Lifting the jaw can facilitate seating the device over the larynx. If you encounter obstruction to ventilation, pull the airway partially back out and reseat it. Fill the cushion with enough air to seal off the air leak.
Intubation still has importance after the initial treatment of a cardiac or respiratory arrest, when you still may need to deliver ventilatory support for a prolonged period of time, or when you need to protect a comatose patient from aspiration of stomach contents. I should also point out that some resuscitation medications can go through an endotracheal tube in the absence of an IV line, and so intubation could save a life when you cannot start an IV, either from a lack of visible veins or from lacking the necessary equipment outside of a healthcare setting. Let's focus now on the actual process of intubation. We will assume that you have ventilated the patient with a mask, have a cardiac rhythm, and have now decided the patient would benefit from intubation. You need a laryngoscope and some supplies, an endotracheal tube with a syringe, and a stylet. The endotracheal tube has a universal adapter at one end. First important tip, make sure that you screw the universal connector tightly into the tube when you remove it from its package. Skipping that step can make you look unskilled later in the process if the connector pops out of the tube. It is not so easy to reattach the connector to the tube once the tube is in the patient. If you look closely at the endotracheal tube, you will find a marking that suggests the appropriate length for oral insertion. Nasal insertion requires the full length of the tube, but nasal placement of the endotracheal tube goes beyond the scope of this presentation. While the endotracheal tube designer intended that the user cut the extra length of the tube off for oral use in order to reduce resistance and dead space, cutting the tube is not necessary in an emergency setting. Attach a 10 milliliter syringe to the pilot balloon at the end of the pilot tube. The pilot tube delivers air to inflate the cuff. Drawing back on the syringe will fully deflate the cuff for insertion. After insertion, the balloon will seal the tube inside the trachea. The cuffed end of the tube is cut diagonally and has a small side opening called the Murphy's eye. The diagonal cut and the Murphy eye attempt to keep the tube patent even if the tube is advanced too far down the trachea. But we will check for that possibility later.
I hate to trouble you with memorizing things, but you'll find it useful to know that a 7mm tube works well with an adult female, and an 8mm tube works well with an adult male. If your memory fails, the size of the tip of the little finger of your patient closely approximates the size of an endotracheal tube that will easily fit into their trachea. On average, the 21 centimeter mark on the tube will fall at the front teeth when the tube is properly positioned in an adult female, and the 22 centimeter mark proves average for the adult male. Laryngoscope blades come in a variety of sizes and shapes. For an adult patient, one would most commonly use a size 2 or 3, moving up to a size 4 for the patient with a larger than normal head. The commonly used curved blade is also called a Macintosh blade, and the most commonly used straight blade is called a Miller blade. The best blade is the one with which you have the most practice. Anesthetists usually have a preference for one or the other, but either blade used properly can get the job done 19 times out of 20.
Sometimes some historical perspective makes information stick in your mind. Way back in the late 18th century, physicians began looking down people's throats using tubes and mirrors. But not until 100 years later, at the end of the 19th century, did the first laryngoscope come along. Alfred Kirstein, a German physician, gets credited for that advance. Anesthesiologists did not get into the throat-looking act until the early part of the 20th century, when Dr. Henry Janeway of New York City popularized catheterizing the trachea to improve nose and throat surgery. The folding laryngoscope finally came along in the 1940s, in the latter part of World War II, and a variety of blade designs came into use. The Mac blade was named after Sir Robert Mackintosh, who grew up in New Zealand. Mackintosh became a professor of anesthetics at the University of Oxford in England, where he noticed that the Boyle-Davis gag used for tonsillectomies made the vocal cords easily observable because it indirectly lifted the epiglottis by applying force to the anterior throat. His observation led to the creation of the curved Mackintosh blade, presented in a landmark paper published in 1943. In 1941, Robert Miller, an American anesthesiologist, designed the now popular Miller straight blade, featuring a slight upward curve at its tip. The Miller blade lifts the epiglottis directly. Several studies in the anesthesia literature suggest that the Mac curved blade is easier for beginners to master, while the Miller blade appears to have a slight advantage for success in difficult intubations.
A stylet inside the endotracheal tube can make insertion easier by holding the tube in a particular bend. Usually, a smooth curve works best with a curved blade, and a hockey stick bend in the tube works best when using the straight blade. The back end of the stylet should be bent over at the adapter, so the front end does not protrude beyond the tip of the tube. Keeping the end of the stylet inside the endotracheal tube minimizes the chance of the stylet causing any injury to the patient's airway. The stylet often sticks to the endotracheal tube, and pulling it back creates an opportunity to dislodge the tube. So remove the stylet very carefully while holding tightly to the tube so it does not come out of the patient along with the stylet. Anesthesiologists often lubricate the stylet to make removal easier, but that step would not prove practical in an emergency. So now I'm ready to intubate. I position the patient with a cushion under the head to lift the head so that the trachea is angled upward towards me, the so-called sniffing position. Now when I tilt the head back by lifting the chin, I've created a straight line path right through the mouth down to the vocal cords. I'm going to walk you through the process using a curved blade. I can now gently insert my blade into the right side of the mouth, a distance of about 2/3 of the length of the blade. Now I look for the tip of the epiglottis. As I look down the blade, I'm making sure that I lift the tongue by lifting the scope handle upwards towards the junction where the wall meets the ceiling, right in front of me. I definitely do not want to rotate the handle of my scope back towards me because that movement can break teeth. Lift the scope instead of prying against the teeth. The front teeth should never serve as a fulcrum to pry open the airway. Once you see the tip of the epiglottis, you know you're in the right territory. Relax tension on the laryngoscope blade so that you can slide or advance the blade easily into the vallecula. With the blade in the vallecula, lifting the blade a second time will show you the vocal cords.
Seeing the vocal cords distinctly is the key skill in intubation, so I'm going to repeat these steps for emphasis. Number 1, I only lift with the laryngoscope and never pry with it. Number 2, I enter the mouth on the right side. Number 3, I go in about 2/3 the length of the blade and have a look. Number 4, once I see the tip of the epiglottis, I relax my tension and advance the blade into the vallecula. Number 5, I lift the handle a second time to see the vocal cords.
If I were using a straight blade, a Miller blade, instead of a Mac blade, I would slide the tip of the blade under the epiglottis and then lift to see the vocal cords, instead of sliding the blade tip into the vallecula, as I did with the curved blade.
It takes some practice to position the laryngoscope blade to leave space for the tube to advance without obscuring the view. Ideally, the stylet should come out now, and then you can advance the tube so the cuff lies just below the vocal cords. Often you will find it difficult to verify the location of the cuff visually because the tube hides the vocal cords once inserted. We will check later to make sure the tube did not go in too far.
Inflate the cuff so the pilot balloon is still soft, connect your ventilating circuit or bag, and then you can add additional air to seal any leak.
Confirm using a stethoscope that breath sounds have equal intensity in both armpits with no sounds heard over the stomach. Look for bilateral chest movement with ventilation and confirm the presence of CO2 if you have the means to do that. Use tape or a stabilizing device to secure the tube in place.
What do you do if, when you look in with your scope, you fail to see the tip of the epiglottis? Anesthetists refer to this situation by the initials CSS. CSS stands for can't see anything, with that second S coming from an alternative spelling of the word anything. CSS in an emergency situation will definitely get your full attention and quicken your pulse even more than it was already. But I'm going to give you a strategy for a brilliant, heroic recovery. Back out just a little bit with your blade, because your initial enthusiasm may have encouraged you to slide that blade in too far, right by the epiglottis and into the esophagus. Even I have made that mistake. No one will notice such a little detour, and once you back out and see the tip of the epiglottis, you're right back on the right track. But stick with me now, because the tactical retreat just described may not fix the CSS problem in all cases. Recovery maneuver number 2 involves reaching up with your right hand to feel the larynx, and then move the larynx from side to side as you look down the blade. Sometimes you're off to one side with your blade, and the movement will allow you to see how to correct the problem. If it's still not happening, don't panic. Instead, go right to maneuver number 3, provided you have someone able to help you. A second person can either push down on the larynx or push down on the back of the subject's head to provide a little better alignment of the key structures. The recommended way to push on the larynx, books call the BURP method. BURP, B-U-R-P, stands for backward, upward, rightward pressure. In other words, push the larynx toward the tip of the laryngoscope blade, backward, upward, and rightward. If burping fails, jump to maneuver number 4. You confidently back all the way out, slip in an oral airway, and ventilate again with a mask. No dishonor, no foul. You didn't see any vocal cords, not your fault. And you didn't endanger the patient by putting the tube in the esophagus. You did no harm, you are still a hero.
I certainly do not claim to know as much about the failed intubation as Dr. Gibb, but I totally agree with both Dr. Gibb and Hippocrates about doing no harm. Fortunately, my hero, the British physician Dr. Archie Brain, has invented the laryngeal mask airway, and that device, the LMA, can provide a rescue airway when intubation fails. Not quite as secure as an endotracheal tube, but better than a raw, bleeding airway. Adult women generally need a number 4 LMA, and men a number 5. The LMA package provides guidance on the right device size based on the patient's weight, but number 4 for females and number 5 for males usually works. Anesthetists have invested a lot of energy in finding a way to predict which of their patients will fall into the CSS category. Don't worry about that stuff. The emergency responder has to do the best he or she can with the situation presented to them. But please do spend some time practicing with the LMA in the lab so you feel confident that you can fall back on the LMA as an airway rescue device.
Great job, guys. Now we are going to send you to the lab to practice intubation, mask ventilation, and LMA placement on a mannequin. The mannequin differs from the human subject, but if you learn to recognize the epiglottis and vocal cords and practice lifting up with the scope, you have the important fundamentals. The lab will help you get the feel of the laryngoscope and the tube so these tools feel natural in your hand. Remember, you can save lives with a bag and a mask, and the LMA can also safely stabilize most comatose patients. The LMA can be a very welcome friend in an emergency. You have the concepts, so go save the life of a mannequin today with confidence, so you will be much more comfortable when you encounter a real emergency situation.